Today our topic is hypothyroidism. Yesterday it was hyperthyroidism. Today is hypothyroidism. Hypothyroidism is a condition caused by a structural or functional derangement that interferes with the production of thyroid hormone. The prevalence increases with age and it is nearly tenfold more common in women than in men. Hypothyroidism can result from a defect anywhere in the hypothalamic-pituitary-thyroid axis. Like hyperthyroidism, it can be divided into primary and secondary forms, depending on whether it arises from an intrusive thyroid abnormality or as a result of pituitary and hypothalamic disease. So primary hypothyroidism can be congenital, can be autoimmune, can be iatrogenic. 3 types. Congenital hypothyroidism. Worldwide, congenital hypothyroidism is most often the result of endemic iodine deficiency in the diet. Other rare forms of congenital hypothyroidism include inborn errors of thyroid metabolism, wherein one of the several steps leading to thyroid hormone synthesis is defective. Number 1 is iodine transport into thyrocyte. Number 2 is organification of iodine. Number 3 is further processing to form hormonally active T3 and T4. In rare instances, there may be complete absence of thyroid parenchyma, that is called thyroid agenesis. Or the gland may be greatly reduced in size, that is called thyroid hypoplasia, due to germline mutation in genes responsible for thyroid development. Then autoimmune hypothyroidism. Autoimmune hypothyroidism is the most common cause of hypothyroidism in iodine sufficient areas of the world. It occurs in iodine sufficient areas. The vast majority of cases, autoimmune hypothyroidism are due to Hashimoto thyroiditis. Circulating autoantibodies including antimicrosomal, anti-thyroid peroxidase, and anti-thyroglobulin antibodies are found in this disorder, and the thyroid is typically enlarged. So the circulating antibodies are: number 1 is antimicrosomal, number 2 is anti-thyroid peroxidase, and number 3 is anti-thyroglobulin antibodies. Autoimmune hypothyroidism can occur in isolation or in conjunction with autoimmune polyendocrine syndrome types 1 and types 2, APS1 and APS2. Then iatrogenic hypothyroidism. This can be caused by either surgical or radiation-induced ablation. Resection of a large portion of the gland for the treatment of hyperthyroidism or a primary neoplasm can lead to hypothyroidism. The gland may also be ablated by radiation, whether in the form of radioiodine administered for the treatment of hyperthyroidism or exogenous irradiation such as external radiation therapy to the neck. Then drugs given to decrease thyroid secretion can also cause acquired hypothyroidism, like methimazole and propylthiouracil. As can agent to treat non-thyroid condition, lithium P-amino-salicylic acid. So these drugs can cause hypothyroidism. Methimazole, propylthiouracil, lithium P-amino-salicylic acid. So it is the cause of hypothyroidism is congenital, autoimmune, and iatrogenic. Then another type, secondary or central hypothyroidism. Secondary or central hypothyroidism is caused by deficiencies of TSH or far more commonly TRH. Any of the causes of hypopituitarism, pituitary tumor, postpartum pituitary necrosis, trauma, and non-pituitary tumors, or hypothalamic damage can cause central hypothyroidism. So the causes of hypothyroidism, number one is primary, number two is secondary. Among primary, genetic defects in thyroid development, thyroid hormone resistance syndrome, post-ablative, surgery, radioiodine therapy, or external irradiation, autoimmune hypothyroidism, Hashimoto thyroiditis, iodine deficiency, drugs, congenital biosynthetic defect, and among the secondary are central hypothyroidism, pituitary failure, and hypothalamic failure. The clinical manifestation of hypothyroidism, depending upon the age and onset of disorder, are divided into two forms. Number one is cretinism, and number two is myxedema. Cretinism is congenital hypothyroidism. Is the development of severe hypothyroidism during infancy and childhood. That is called cretinism. And myxedema is adulthood hypothyroidism. When hypothyroidism occurs in children or infancy, it is called cretinism. When it is in adult, it is called myxedema. Now, cretinism. A cretin is a child with severe hypothyroidism present at birth or developing within first 2 years of postnatal life. This is the period when brain development is taking place. In the absence of treatment, the child is both physically and mentally retarded. In the past, this disorder occurred very commonly in regions of the world where dietary iodine deficiency is endemic. Which area? It is Himalayas, China, Africa, or other mountainous area where iodine deficiency is endemic. It is now much less prevalent as a result of the widespread supplementation of foods with iodine. On rare occasion, cretinism results from genetic defects that interfere with the biosynthesis of thyroid hormone. Now the etiopathogenesis. Number one is developmental anomalies, thyroid agenesis and ectopic thyroid. Number two is genetic defect in the thyroid hormone synthesis. Example, defect in iodine, trapping, oxidation, iodination, coupling, and thyroglobulin synthesis. Number three is endemic cretinism in regions with endemic goiter due to dietary lack of iodine. Then clinical features. The clinical manifestations usually become evident within a few weeks to months of birth. The presenting features of cretin are slow to thrive, poor feeding, constipation, dry skin, hoarse cry, and bradycardia. As the child ages, clinical pictures of fully developed cretinism emerges, characterized by impaired skeletal growth and consequent dwarfism, round face, narrow forehead, widely set eyes, flat and broad nose, big protuberant tongue, and protuberant abdomen. Neurological features such as deaf mutism, spasticity, mental deficiency are more evident. Characteristic lab finding include a rise in TSH level and falling T3-T4 level. TSH level will increase, T4 level will decrease. Then myxedema. Myxedema is adult-onset hypothyroidism. Adult onset. The term myxedema connotes non-peaking edema due to accumulation of hydrophilic mucopolysaccharides in the ground substance of dermis and other tissues. Clinical features. Myxedema is marked by a slowing of physical and mental activity. Early symptoms include generalized fatigue, apathy, and mental sluggishness, which may mimic depression. Speech and intellectual functions are slowed, and patients are listless, cold intolerant, and frequently overweight. Decreased sympathetic activity results in constipation and decreased sweating. The skin is cool and pale because of decreased blood flow. Reduced cardiac output probably contributes to shortness of breath and decreased exercise capacity to frequent complaints. The onset of myxedema is slow and fully developed clinical syndrome may appear after several years of hypothyroidism. The striking features are cold intolerance, mental and physical lethargy, constipation, slowing of speech and intellectual function, puffiness of face, loss of hair, and altered texture of skin. Lab evaluation. Lab evaluation plays a vital role in the diagnosis of suspected hypothyroidism because of the non-specific nature of symptoms. Patients with unexplained increase in body weight or hypercholesterolemia should be assessed for potential hypothyroidism. Measurement of the serum TSH level is the most sensitive screening test for this disorder. The lab diagnosis in myxedema made by low serum TP54 and markedly elevated TSH level. Now, Hashimoto thyroiditis. Another name is autoimmune thyroiditis or chronic lymphocytic thyroiditis. Hashimoto thyroiditis is an autoimmune disease that results in destruction of the thyroid gland and gradual and progressive thyroid failure. It is the most common cause of hypothyroidism in areas of the world where iodine levels are sufficient. So, Hashimoto thyroiditis occurs where iodine levels are sufficient. Hashimoto thyroiditis, also called diffuse lymphocytic thyroiditis, is characterized by three principal features. Number one is diffuse goitrous enlargement of the thyroid. Number two is lymphocytic infiltration of the thyroid gland. And number three is occurrence of thyroid autoantibodies. Hashimoto thyroiditis occur more frequently between the age of 30 and 50 years and shows an approximately 10-fold preponderance among females. Etiopathogenesis of Hashimoto thyroiditis. Hashimoto thyroiditis is an autoimmune disease is well established. Hashimoto, a Japanese surgeon, described it in 1912 as the first autoimmune disease of any organ. Autoimmune pathogenesis of Hashimoto thyroiditis is explained by the following observations. Number one is other autoimmune disease association. Like in many autoimmune diseases, Hashimoto's disease has been found in association with other autoimmune diseases such as Graves' disease, SLE, Sjogren's syndrome, and rheumatoid arthritis. Number two is immune expression of thyroid cells and association of cytotoxic lymphocyte association antigen 4, CTLA4, a T-cell regulatory gene with autoimmune phenomenon in Hashimoto's disease has been reported. There is initial activation of CD4 plus T helper cell, which then induce infiltration of CD8 plus T cytotoxic cells. Number three is detection of autoantibodies. Autoantibodies are number one, thyroid microsomal autoantibodies, thyroid globulin autoantibodies. Number three is TSH receptor autoantibodies. So the mechanisms are, number one is Other autoimmune disease association like in many autoimmune disease like Graves' disease, SLE, Sjogren's syndrome. Number 2 is CTLA4 involvement, activation, and number 3 is detection of autoantibodies. So, this is the pathogenesis of Hashimoto thyroiditis, normal thyroid epithelium, breakdown in self-tolerance, and invasion of thyroid autoimmunity. So, after breakdown of self-tolerance, autoimmunity develops, and thyroid cells are destructed by T-cell mediated cytotoxicity, thyroid injury, antibody-dependent cell-mediated cytotoxicity, mechanism of thyroid cell destruction. Then induction of thyroid autoimmunity is accompanied by a progressive depletion of thyroid epithelial cells and replacement of the thyroid parenchyma by lymphocytic infiltrates and fibrosis. Multiple immunologic mechanisms may contribute to thyroid cell death, including CD8 plus cytotoxic T-cell mediated cell death, cytokine mediated cell death, activation of CD4 plus T helper cell leads to the production of inflammatory cytokines such as interferon gamma in the thyroid gland, with resultant recruitment and activation of macrophages and damage to follicles. A less likely mechanism involves binding of anti-thyroid antibodies, anti-thyroid globulin, and anti-thyroid parasitase antibodies, followed by antibody-dependent cell-mediated cytotoxicity. Now, morphologic features. Grossly, the classic form of characterized by diffuse, symmetric, firm, and rubbery enlargement of the thyroid, which may weigh 100 to 300 grams. Histologically, there is extensive infiltration of the gland by lymphocyte, plasma cell, immunoblast, and macrophages, with formation of lymphoid follicles having germinal centers. There is decreased number of thyroid follicles, which are generally atrophic and are often devoid of colloid. Number 3 is the follicular epithelial cells are transformed into their degenerated state termed Hürthle cells. Hürthle cells are also called asterology cells or oxyphil cells or oncocytes. These cells have abundant oxyphilic or eosinophilic and granular cytoplasm due to large number of mitochondria and contain large visceral nuclei. There is slight fibrous thickening of the septum separating the thyroid lobules. Now the clinical features. The presenting features of Hashimoto thyroiditis is painless, firm, and moderate boisterous enlargement of the thyroid gland, usually associated with hypothyroidism in a middle-aged woman. At this stage, serum T3 and T4 levels are decreased, and radioactive iodine uptake is also reduced. Hashimoto thyroiditis most often comes to attention as painless enlargement of the thyroid, usually associated with some degree of hypothyroidism in a middle-aged woman. The enlargement of the gland is generally symmetric and diffuse, but in some cases it may be sufficiently localized to raise the suspicion of a neoplasm. In the typical case, hypothyroidism develops gradually. Individuals with Hashimoto thyroiditis are at increased risk for developing other autoimmune diseases. Other autoimmune diseases like endocrine type 1 diabetes, autoimmune adrenalitis, and non-endocrine SLE, myasthenia gravis, and Sjogren's syndrome. These are the other autoimmune diseases. They are also at increased risk of development of extranodal marginal zone B-cell lymphoma within the thyroid gland. So this is the picture of Hashimoto thyroiditis. You can see here, these are the atrophic follicles, these are the lymphoid follicles, lobular septa, These are all lymphocytes, and these are Hürthle cells, and all are lymphocytes. This is also a picture of Hashimoto thyroiditis. These are all lymphocytic infiltration. So, the main thing is here is pathogenesis of Hashimoto thyroiditis. So, etiopathogenesis of Hashimoto thyroiditis. Number one is other autoimmune disease association, like in many autoimmune diseases. Hashimoto disease has been found in association with other autoimmune diseases like Graves' disease, SLE, Sjogren's syndrome, rheumatoid arthritis. Number two is immune destruction of thyroid cells as an association of cytotoxic lymphocyte associated antigen 4, CTLA4. It is a T-cell regulatory gene with autoimmune phenomenon in Hashimoto disease has been reported. There is initial activation of CD4 plus T helper cell, which can induce infiltration of CD8 plus T cytotoxic cells. And number three is detection of autoantibodies. The following autoantibodies against different thyroid cell antigens are detectable in the serum of most patients. Number one is thyroid microsomal autoantibodies. Number two is thyroid globulin autoantibodies. Number three is TSH receptor autoantibodies. And this is the pathogenesis of Hashimoto thyroiditis. Normal thyroid epithelium breakdown in self-tolerance. After breaking down the self-tolerance, autoimmunity develop, and by T-cell mediated cytotoxicity and interferon gamma and thyroid injury and antibody-dependent cell-mediated cytotoxicity. These are the three mechanisms by normal thyroid glands are destroyed.